I'm Lisa Israel, and welcome to my presentation on the management of a patient with chronic migraines. Let's begin with some background information on our patient. Wendy is a 30-year-old female. She is a full-time nursing student at USM, and she resides in Portland, Maine. She has come into the office today to discuss some options for a preventative medication for her migraines. Unfortunately, her migraines have increased in frequency. She's now having them approximately 3 to 4 times a week. The good news is that her sumatriptan does treat the migraines, but the frequency has just become unbearable. Wendy has always been good about avoiding dietary triggers. She takes a daily supplement of B2 and magnesium to help prevent migraines, but unfortunately they're not helping her at this time. She is good with trying to manage her stress. She does yoga. She's physically fit and active. She likes to bike and hike. But as we said, her migraines have become way too frequent, and as she said, it's getting really expensive. Looking at Wendy's relevant medical history, we see that she is up to date with all recommended vaccinations. She hasn't had any major illnesses in her lifetime, no recent injuries. Her only surgical history is that she had her wisdom teeth removed when she was 19. She's never been pregnant. She's good with her health maintenance and screenings. Her last pap smear was about 3 months ago. It was normal. She is a non-smoker. She says she does have the occasional social drink, but it works out to be fewer than 2 drinks a week. And unfortunately, she's here because of her migraines. Her migraines have bothered her since she was about 15 years old. They occur without auras. She educated herself on what foods and triggers to avoid, and she is consistent in avoiding them. She is able to manage the pain with either NSAIDs or her sumatriptan prescription. The only other medication she takes is an oral contraceptive, Seasonal. That is the 3-month-long birth control pill. She's not had any difficulties with that, and she has no known drug allergies. Now, with her migraines occurring 3 to 4 times a week and happening over the last several months, we now consider that chronic migraines, which is defined as at least 15 headaches in a month, with at least 8 of those being migraines. She has exceeded that definition. In examining Wendy today, we see that she is 5 feet 2 inches tall. Weight is 143 pounds, so all that has been consistent. Her BMI is 26. Her blood pressure is good at 118/72. Her heart rate is 76 and regular. Respirations are 16 and regular. Her temperature is textbook normal, 98.6. And in reviewing her systems, we find nothing abnormal, and her overall health is good. The only reason she's here is the increased frequency of her migraines. There have been no other changes in symptoms, so no new symptoms with her migraines, no worsening of symptoms, no increased pain. So nothing has changed except that she's having too many migraines each week. Before we delve further into the diagnosis and treatment of Wendy's migraines, let's review the criteria for defining what is a migraine and what constitutes chronic migraines. Wendy's migraines are textbook. If she doesn't treat them, they last several hours, sometimes even a couple days. She says they're unilateral, usually on the right side. They have that throbbing, pulsating pain, which is severe. She also wants to just curl up in bed in a quiet, dark, cool room whenever her migraines hit. She does have nausea, although rarely vomiting with her migraines. She is sensitive to light and sound. And unfortunately, this has been going on for 5 to 6 months at least now, she says, and more than half the month is affected by these migraines. So she definitely fits the criteria for migraine definition as well as chronic migraines. Before we prescribe a new medication for Wendy's migraines, we need to consider any other potential causes of these headaches. So for differential diagnoses, tension headaches, well, she is under a lot of stress these days. She's a full-time nursing student at USM. Tension headaches could be causing some of her discomfort. However, relaxation and massage don't seem to provide any relief for these migraines. It's her usual throbbing pain that she gets with her migraines. It's not an achy feeling. She doesn't report any associated muscle tension with these headaches. Subarachnoid hemorrhage, that is a serious condition that we need to consider, definitely don't want to overlook, that could be causing her some discomfort. But these headaches, they are consistent with her lifelong pattern of migraines. So I don't think a subarachnoid hemorrhage is likely at this time. Could she have had an injury and, a trauma that is causing these headaches? And she does not recall any recent injuries or trauma, and she's not showing any signs of injury or trauma, so I don't think that's what's going on. Meningitis can certainly cause headaches. However, she has no fever, no stiff neck, no other signs of illness, so I don't think meningitis is likely at this time. And of course, we need to always consider that there's something else going on in her brain. Is she developing a mass or a tumor? However, the good news is she's not had any change in the severity of her headaches. She's not had any seizures. Nothing in her symptoms has changed other than the frequency. So I'm not concerned about something developing in her brain at this time. So we have established that Wendy meets the criteria for chronic migraines, and we don't think that there's any other condition going on, so she needs preventative treatment for her migraines. And the good news is we have several drugs to choose from. I'm sure we will find one that's right for her. Anti-epileptic drugs have shown to be very beneficial in migraine prevention. Topamax, Depakote, Depakon are all viable options. We have beta blockers. Propranolol is a common one, but timolol, atenolol, there are others if for some reason propranolol is not working for her. We have antidepressants that could be beneficial for migraine management. Amitriptyline, venlafaxine, and so far all of these drugs are available in generic form, the anti-epileptics, the beta blockers, the antidepressants, so we should be able to have good availability and low-cost options. There are some new medications available for migraine management. CGRP inhibitors, these are new, relatively new injections for migraine management. Unfortunately, they are very expensive and not likely to be high on Wendy's list at this time. So Wendy has some thoughts on things she wants to consider before starting a new medication. First and foremost, she's here today because of the cost of treating her migraines. Yes, they're affecting the quality of her daily life, but also they're costing her a lot of money each week, and she would like a lower cost treatment option, and I can understand that. Additionally, we always need to think about anything that may be contraindicated for our patients. Wendy's a female of childbearing age, and specifically the anti-epileptic drugs carry a high risk of birth defects. So only women who are using reliable birth control and who are not planning on becoming pregnant anytime soon should use those medications for migraine management. And always we need to consider potential side effects and which of our patients may be more susceptible to different medication side effects. So beta blockers, they reduce blood pressure, so they can cause fatigue, orthostatic hypotension, dizziness, etc. And the good news is that Wendy is a healthy young female who hopefully won't be bothered by these side effects of beta blockers. If she wants to consider an antidepressant, some of those side effects are weight gain, sexual difficulties, fatigue, nausea. And so, once again, hopefully those are minimal, but something to consider with our patient. And then, besides the big contraindication of anti-epileptic drugs and our patients of childbearing age, they can also cause dizziness, sleepiness, memory problems, and so those are things to take into consideration. So we've covered a lot of potential treatments for migraine management. What's the best one for Wendy today? Well, in talking to Wendy, her concerns include the fact that although she's not planning on becoming pregnant at this time, she is in a long-term committed relationship and she hasn't ruled out the possibility that she could become pregnant in the next couple years. So the anti-epileptic medications are not her first choice at this time, and so she wants to continue looking at the other options. So the antidepressants. Well, Wendy has several friends who have used or are currently using antidepressants, and she is concerned that several of them have had difficulties with weight gain and lowered libido and some GI distress, and she doesn't want to risk that at this time. So onward through our options we go. Definitely the newer CGRP inhibitors are not tops on her list. They are too expensive and she doesn't want to deal with the monthly injections. So that leaves us with the beta blockers, and she would like to see if a beta blocker would be a good fit for her and managing her migraines. So this is pharmacology class. Let's talk pharmacology of beta blockers. So how do beta blockers work? They act directly on the beta adrenergic receptors, so they relax the blood vessels in the body. They also reduce heart rate and the force of contraction of the heart. As a result of these cardiogenic effects, the blood vessels in the brain are stabilized and are much less likely to overdilate, and that is what triggers the pain of a migraine, is that vasodilation in the brain. Also of interest is that beta blockers have been found to cause a change in the brain's electrical activity. I'm not a neurologist and this is not neurology class, so don't ask me to explain it in detail, but there's a type of electrical activity in the brain called cortical spreading depression that is associated with migraines, and beta blockers are thought to interrupt and prevent this activity. Also, beta blockers can increase activity in the hypothalamus, another part of the brain that may be associated with migraines. So what are some common side effects of taking beta blockers? Well, because of the cardiogenic effects, fatigue, weakness, dizziness, hypotension, also diarrhea, nausea. Hopefully these are minor. Oftentimes after a patient has acclimated to the medication, after a couple weeks, they go away altogether. Wendy is young and healthy. I'm not too concerned about side effects with her. Some adverse effects to consider. Always you want to look for anaphylaxis and Stevens-Johnson syndrome with many medications. Beta blockers, specifically, we want to be on the alert for cardiac arrhythmias and they can also trigger bronchospasm. So things to look for that are more serious side effects, but fortunately they're rare. For safety and monitoring, because this has cardiogenic effects, once again, we want to make sure that we keep up with tracking her blood pressure and heart rate and make sure they don't go too low. The good news is that beta blockers aren't going to interact with anything else she's taking. Her only prescribed medication is the birth control, and a beta blocker is compatible with her birth control as well as her supplements that she takes. So what is the treatment plan? I would like to prescribe propranolol extended release for Wendy. This will be an 80 milligram tablet that she takes once a day. This is generic for Inderal LA, so she should be able to get it at a reasonable cost. Full effect should be seen in 4 to 6 weeks. If she does not get satisfactory results by 4 or 6 weeks, we will need to taper her off of this medication. This is not a medication that you can discontinue suddenly, and I will educate her about that caution. But the good news is we have lots of other choices, so we will try another medication if this one does not work. I would like to follow up with her in 2 to 3 weeks just to make sure that her vital signs are okay, specifically her blood pressure and heart rate, and see if any side effects are intolerable at this time. However, I'm not too worried about that. I will also encourage her to continue to seek ways to minimize her stress, to reduce any potential migraine triggers she encounters. And since she hasn't tried biofeedback before now, I'm going to encourage her to look into that. Research studies are showing that biofeedback used as an adjunct therapy to medication is very effective in reducing migraines in many patients. So what is the latest and greatest in migraine treatment and interesting things on the horizon? Well, more about the biofeedback. There are now home treatment options that are available for about $100 or even less. There are galvanic skin response devices. There are a couple different ones out there in the market, and they're easily obtained. Online retailers like Amazon or places like Walmart, believe it or not, have them, and they measure skin temperature and other indicators of stress and blood flow. And some patients get great results doing biofeedback, and it's no longer this expensive treatment that requires an appointment with a specialized therapist to utilize it. So for $75 to $100, she might have a great adjunct therapy to reduce her migraines and increase her quality of life. So it's something worth exploring. Also, just out this week, there is a new oral dissolving tablet medication to treat acute migraines. It's seeking FDA approval. It's called Rimegepant, and it is a CGRP receptor agonist. There are a couple other drugs in the same class that are also in development. So I think there is a whole new class of medications on the horizon to help our patients with severe migraines. Thank you for listening to my presentation on managing a patient with chronic migraines. Hope you learned something or found something of interest. I recommend checking out the American Headache Society and the American Migraine Foundation for information specific on migraines and migraine treatment. As well, prescribing information can be found at Hippocrates, Medscape, GoodRx. Lots of resources for you to find appropriate medications for your patients. I also use the CDC medical eligibility criteria chart to make sure that Wendy's contraceptive was not an issue in her migraine medication management. And finally, I just want to say that the good news is that patients like Wendy have lots of choices these days. Just a couple decades ago, patients were told that migraines were just in their head and often left their provider's office with nothing to relieve their pain or improve their quality of life. So there's lots we can do now for our patients with migraines, and I hope that you found this presentation of some benefit in learning about those choices. So thank you and have a great day.